Okay, so I'm taking a bit of artistic license here because when I saw the topic, the challenge was that I am not a reproductive endocrinologist and gynecologist who does infertility treatment. And the other problem with this topic was that you've got some experts in Rob Norman and Duru Shah who are going to talk to you about infertility treatment. So I'm going to take a little bit of artistic license and talk a little bit more about hyperinsulinemia, hyperandrogenemia and treatment of those. And then you'll get more information from Rob and Duru and others about specific treatments in infertility. And in discussion with them, we may also touch on some of the guideline recommendations tomorrow about infertility treatment. So, as we talked about before, and I've got the main problems here in this condition are lifestyle and genetics, the fact that the obesity increases the androgens and increases insulin resistance, but they are both inherently increased in PCOS independent of that obesity. So in terms of treating the condition, the important thing is that when we start with tailored treatment, life stage, cultural issues and personal factors are all very important. I'll talk a little bit more later on today about lifestyle treatment, but the guidelines focus very importantly on the fact that every woman with PCOS should have lifestyle therapy, no matter what their BMI, no matter what their age, because the focus should be around prevention of weight gain. And I can tell you it's an awful lot easier to do prevention of weight gain, which you can do as a clinician, and the studies show it takes very little effort and time to measure a young woman's weight and waist circumference, to talk to them about how important it is not to put on weight for fertility outcomes and to work with them around those goals, than it is to try and reverse the weight scenario when they're already overweight. I'm going to take the liberty of assuming that not all of you are quite so familiar with the obesity treatment literature, but the reality is now that around the world, and this is not specifically in Southeast Asia, of every 1,500 obese women, only one of those 1,500 in 5 years will become a healthy weight and stay there. So if you have a patient population who are very overweight and they're coming in to see you and you're saying you need to get back to a healthy weight with lifestyle change, it's just not going to happen. But you can definitely get them to lose 5% of their body weight and make a difference, and we'll talk about that later this afternoon. The biggest difference you can make is from that young woman all the way through onwards, is to get them to prevent further weight gain. And one of the critical things about that is they must be monitoring. They don't know what their weight is. That's a real problem. And Rob mentioned before that a lot of gynecologists don't do the BMI, they just look at women. So the big problem with that is we all look at them and think they look fine. And actually their BMI is getting higher and higher. So clinicians and women now completely normalise obesity, and such that the standard clothing size, for example, of a size 10 or a size 12 or a size 14 is actually getting bigger. So women are staying in the same size clothes, but in fact they're actually putting on weight. So our assessment of BMI by glancing at someone is influenced by the BMI of the people we see around them. And it really is important to measure it, because actually often we're surprised. So monitor their weight, monitor their waist circumference in your context, make sure they know that they only need to make very small changes to prevent weight gain. And target the therapy, the women's primary concern. So the reason I say that is one of the biggest things that came out in guideline development from women is, as I said before, the specialists treated the thing they were most comfortable with and didn't treat the thing that mattered the most to the woman. So make sure you know what that is. So in terms of medical therapy, when we're talking about addressing hyperandrogenism and hyperinsulinemia, the topics that were prioritised by health professionals and women were the role of the combined oral contraceptive pill alone, oral contraceptive pill combined with other agents, metformin, anti-androgens, anti-obesity agents, and inositol. Just to note that almost everywhere in the world, combined oral contraceptives, metformin, and other medications for PCOS are all actually off-label if we're using them for PCOS. So yes, the pill is indicated for hirsutism, but in fact none of these medications are indicated for PCOS. The problem is most of them are also not are allowed to be used for PCOS, but women do need to be informed that they are off-label. So in terms of the oral contraceptive pill, alone or combined for PCOS, what did we end up recommending? So important messages were that the pill alone should be recommended for adults if the primary problem is clinical hyperandrogenism and irregular menstrual cycles. And that's the most effective treatment in that case. It needs to be a combined oral contraceptive pill because the most effective mechanism of action is the estrogen going through a first-pass metabolism in the liver and altering the sex hormone binding globulin. So NuvaRing and other forms of contraception don't do that, and therefore they have nowhere near the efficacy in PCOS. So they should be recommended for treatment in adults. They can be considered in adolescents with a clear diagnosis of PCOS, or in that very early young woman who's postmenarchal and you've only deemed her at risk, she doesn't quite meet the criteria yet. She can be commenced on the pill, however she needs a reassessment plan. We reviewed all the literature about the different doses and types of progestins and estrogens in the different pills, and there is no one ideal contraceptive pill, and I'll talk about why in a minute. But you don't need a fancy progestin. The biggest issue here is that the pill needs to contain oral estrogen, and it does not need to be high dose. So pretty much most of the oral contraceptive pills have similar efficacy. They all work for hirsutism because they all affect sex hormone binding globulin. So you can use low dose, and the progestin is largely irrelevant. And that's both from the general literature and in PCOS. But one thing we have done, which is important and different to current clinical practice, is made the point that there really is very little role for the 35 microgram ethanol, estradiol and cyproterone acetate preparations, and consistent with the WHO recommendations for the general population, these agents should not be used first line in PCOS. And the main reason for that is they don't have any better efficacy, they have a higher side effect profile, and there's no benefit from the higher dose estrogen or that particular progestin. So when you're prescribing the pills, they all pretty much work the same in terms of efficacy with hirsutism, but venous thromboembolic risk is important, and therefore the lower dose preparations are recommended. There is some evidence in PCOS, but more evidence in the general population to inform us. And we should be thinking about, when we're using the pill, high BMI, hyperlipidemia, hyperglycemia and hypertension in these women that we need to be concerned about with pill use. So what about the overall evidence? So almost no one has tested the combined oral contraceptive pill versus placebo, for probably good reason. There is there's one study in adolescents, in fact, but most of this literature is actually looking at the oral contraceptive pill versus metformin. And what we do know is, as you would expect, cycle regularity improves on the combined oral contraceptive pill. It doesn't do anything, this is in adolescents, doesn't significantly affect lipids, testosterone or fasting insulin, but in young women in adolescence it did actually cause weight gain in the meta-analysis of the 4 studies that are available. In adults, it improves sex hormone binding globulin, free androgen index, total testosterone and irregular cycles in all BMI groups, and can also improve LDL cholesterol, and didn't show an increase in weight or BMI. So this is actually one of the most important things to understand about using the pill in PCOS. So in terms of testosterone, it's not that the pill particularly lowers the testosterone, although it does, but it actually does it to the same degree that metformin does. The difference is that it causes a massive increase in sex hormone binding globulin. And it's that increase in sex hormone binding globulin due to oral estrogen that underpins the reason you use the pill. That's why a lower dose oral estrogen and the progestin does not matter. But it's also why it's far more effective than metformin, which will also lower testosterone but does not affect sex hormone binding globulin anywhere near as much as the pill. So what about metformin alone? So this is addressing insulin resistance in these women. So is it alone or in combination effective for the management of PCOS? And the literature actually, there are many, many studies on this. The literature actually is now more confirmatory than not. It's not a panacea, it will not fix everything, it should not be in the drinking water. But metformin, in addition to lifestyle, can be recommended in adult women for the treatment of weight outcomes. They have a better BMI. they have a better weight outcome, and this is over data out to 2 years now, and better metabolic outcomes. So keeping in mind, and it may not be the same in Southeast Asian populations, but for the majority of women who report it, weight gain and prevention of weight gain is really important. So in that case, we know there's a significant difference in BMI if women use metformin, mainly in terms of prevention of weight gain. It does improve testosterone, but as I said, not SHBG to any significant outcome, and it does improve metabolic outcomes. We made the point that it was even more potent, so we used the word could be recommended in all women, but should be considered if they have a higher BMI, because the evidence for efficacy is high there, and in the Southeast Asian population, you would consider that over a BMI of 23. Metformin, in addition to livestock, would be considered in adolescents with a clear diagnosis of PCOS. And we made the point again that in high metabolic risk groups and in a different part of the guideline, we've included Southeast Asians in that population. So gynecologists are generally less comfortable prescribing metformin than endocrinologists because we use it first line for the treatment of diabetes, type 2 diabetes. So for us, we use it very regularly. It's been around for over 7 decades. It originally came from an extract from lavender, which my patients always like to know. So it was originally extracted from a natural product. It is really, as far as medications go, very safe. As long as your patient doesn't have cardiac or renal failure, they're very much not at risk of going into lactic acidosis. So the adverse effects are generally gastrointestinal, and they're usually dose dependent, and they're often self-limiting. So rather than just putting someone on metformin, they get nausea or they get diarrhea and you say they've not tolerated and take them off, it's actually much better to start at a low dose of 500 milligrams. You increment it. In our case, we do it every 2 weeks, and we give the woman control over the dose she goes up to. So she starts at 500, 2 weeks later she goes up to 1,000, 2 weeks later up to 1,500 at a maximum of 2 grams a day. And if at any one of those levels she gets side effects, she can tolerate them, she stays there, and if she can't, she goes back to her maximum tolerated dose. If you use that sort of regime, almost all the women can tolerate metformin. It's just they'll be on variable doses. As I said, it appears to be safe long-term based on data out to 2 years in studies in PCOS, but mainly out to many, many years, beyond decades, in non-PCOS populations. The only side effect that perhaps is of concern, and there's a systematic review on this now, is the potential for lowering of vitamin B12 with metformin use over time. But we don't recommend routine screening at the moment. As I said, it is at the moment off-label for treatment. So just to highlight, it's not effective for hirsutism. It will give you more ovulation and more cycles, but it's not as effective regulating your cycles as the pill, but it is better for weight and metabolic outcomes. So this is actually the BMI data, and you can see here that it is better for BMI. The average, depending on the weight of a woman, this is a couple of kilos difference, and most of these studies are only 6 months, and that persists if not improves over time. And as I mentioned, it improves testosterone, but really isn't that useful because it doesn't affect SHBG very much. And this is the SHBG data. Despite the fact that it improves insulin resistance, it doesn't do a lot for SHBG. So in summary, there's many studies with metformin alone. It improves BMI, weight, and lipid profiles. Surprisingly, one of the reasons you don't test fasting insulin, there's no difference with metformin on fasting insulin and glucose. And the efficacy of the medication is greater if they're over a higher BMI. So what if you combine these two? If we're talking about treating insulin resistance and the other features, the metabolic features of the condition, along with the pill, is there a role for adding metformin? And again, this is probably where the guidelines will change practice a bit, because what we've recommended is in combination with the pill that metformin should be considered if we're worried about metabolic features. So in your population, that would be particularly prominent. Chandrika was just saying she has a large randomised controlled trial. They've not yet published, and that would be very interesting to look at the results of the pill and metformin in a Southeast Asian population. But in the general population, the evidence is that if you add metformin to the pill, you do get additional efficacy, and I'll show you some of that in a moment. especially if they have a high BMI. And again, that BMI cutoff should be 23 in your population. So to inform us, there are more studies in this, but we only used the most rigorous high-quality studies. There were 7 studies in total that met our criteria, and effectively if you add these two together, you get better glucose, better insulin, lipids. In fact, SHPG is better with a combination than alone, testosterone and free androgen index, and generally the gastrointestinal side effects are fairly mild and self-limiting. If you add metformin to the pill, you don't get a lower BMI than you do with the pill alone. It's only metformin alone that does that. What about anti-androgens? So how many of you use anti-androgens in women with PCOS? So a few, okay. So the surprising thing about this is the literature on this is really poor, and I mean really, really poor. And in fact, what there is out there shows there's really no benefit over the standard use of combined oral contraceptive pill. But the biggest problem with anti-androgens is we tend to use them when we've not given the pill enough time to work. So if you think about hirsutism, it's 6 to 9 months minimum before you see efficacy. And often because these girls find their hirsutism very distressing, we may, and there are some clinicians around the world who have a fairly prominent profile who start young adolescent women on triple therapy with the pill, anti-androgens and pioglitazone, which we do not recommend and is not advised and causes weight gain and is not indicated in reproductive age women. But there is quite a bit of quite many proponents for that. But the reality is, if you look at the evidence, in combination with the pill, anti-androgens should only be added to treat hirsutism after you've had an adequate trial of the pill alone. So please give them 6 to 9 months. And if you need cosmetic therapy in between, that's fine. A word about cosmetic therapy, and this is not from the guideline, so my comment now is from clinical practice, not the evidence-based guideline, because we've set up the first service in Australia where women with PCOS get free laser for their hirsutism, and that was because the women helped us design the service, and that was the most important thing they wanted. And the big problem with laser, and you should inform your population about this too, is that if you go to a beautician, I presume you can get laser at a beautician in India, so if you go and have laser, you can dial the depth of that laser up very easily, up and down. It takes 2 seconds. I now know how to do laser therapy. And so if you're a beautician, you make the treatment very superficial because the woman has to keep coming back and paying more and coming back and paying more. So the problem is many of them now don't get adequate laser therapy because there's an incentive not to do it properly. So if you inform the women about it, and they have to inquire with the beautician who's doing it how deep that they're doing the treatment, and emphasise they want less treatments that are more effective by going deep into the skin and the dermal layer, they will get a more effective, more cost-effective treatment. But if they get that, it's effective. The other problem for your population is skin colour. So darker skin, you need a medical grade laser, basically. And a lot of the lasers are not anywhere near as effective. So in essence, many of the women who need cosmetic therapy in this country should probably be having it with a medically supervised laser. So we did, however, acquiesce that anti-androgens with female pattern hair loss probably should be used with the combined oral contraceptive pill up front. There was some limited evidence for that, but that was the clinical consensus. And the reason is once you lose significant amounts of hair, it's very difficult to recover it. So the other important recommendation, and whilst I don't think anyone in this room would do it, this is actually quite common as a problem with dermatologists, is they will use anti-androgens alone without adequate contraception. And if the woman conceives, we end up with an under-virilized male fetus, and I have seen that several times with resultant terminations. Some of the anti-androgens have potential liver toxicity. Some cause weight gain and mood disturbance. So please, the bottom line is don't use them unless you really need to. What about other medications? As I mentioned, if we're treating hyperandrogenism, using anti-androgens alone, it's not recommended because of their virilization risk. We looked at the literature around anti-obesity pharmacological agents alone or in combination. Do you have access to or use much in the way of oral anti-obesity agents here? Little bit? Okay. So there are obviously quite a lot of agents now coming on the market, but most of them are very expensive. Some of them are injectable. There is evidence of their use in PCOS. And indeed, it is true to say that, as I mentioned before, if you've got quite severe obesity, using lifestyle alone is rarely effective, except for prevention of weight gain. But, and there is a role for anti-obesity agents in the general population, but in PCOS, the evidence is fairly limited, and one thing we all need to remember is there's no literature about the use of these agents during pregnancy. And we're dealing with reproductive age women, so the general population data has to be interpreted with caution. And for that reason, we came to the conclusion they had a limited role. Other agents that may target hyperinsulinemia include inositol, as I mentioned, and there's dicaro and myoinositol are two forms, and we reviewed the literature on the use of these agents alone and in combination. So as I mentioned before, PCOS has evidence of altered inositol metabolism, and therefore higher doses or supplementation of inositol may be useful. The advantage of this is it's a low-cost nutritional supplement available over the counter, so for many women it's a simple treatment. There is evidence and quite a few studies on systematic review that it does regulate menstrual cycles and can improve ovulation, but there's no evidence at all for pregnancy, miscarriage or live birth. So for that reason, we are very cautious about suggesting women use inositol first line. It is potentially promising, but it needs further research. And as mentioned, acupuncture was reviewed, but there just was not enough strong evidence. We've also done a systematic review, which is not part of the guideline, on any of the other agents used in PCOS, including vitamin D supplementation and others. And at the moment, with no exceptions, there's not enough evidence to support the use of supplements or other complementary therapies. The main things I was going to talk about there were the treatment of hyperandrogenemia and the treatment of hyperinsulinemia in PCOS with medical therapy. And I'll talk a little bit later when Rob and I talk about genetics and lifestyle, about the treatment with lifestyle. But I think the main differences with the guideline around treatment were the fact that metformin does have a role in treatment, mainly around management of weight and metabolic features, and while it does regulate ovulation, and that in addition to the oral contraceptive pill, it may also have a role in terms of increased efficacy. There is some evidence for metformin now in terms of infertility treatment, but we'll talk about that in a later session.